All right.
All right, so we're going to be talking about ventilator management today, and it's really a three-part lecture, so this will be the first of the three parts. The way I usually try and approach this is from sort of a historical approach of how ventilators developed. And the reason why I do that is because the problems that we had with they had with ventilators initially, types of ventilation, the modes of ventilation, the issues that were present back then are still present today with some of the newer modes of ventilation. Specifically some of the pressure modes of ventilation, which was the original type of ventilation. There are a lot of issues with that. So I think it's a good way to understand really what the problems are with the various types of ventilation modes, and how they evolved and why they evolved. I think is important to understand. And I think it helps you understand more about the advantages and disadvantages of the different types of ventilation. Okay, so the first type of ventilation worldwide, but particularly in the United States, that was really widespread was what? You have any idea what type of ventilation it was? Or when that might have been?
Iron lung.
Yeah, good. So the iron lung. So when was that? That was like, okay, so it was mostly in the 50s. Okay, that was during the polio epidemic in the 1950s. So it was, and what principle did it use? What kind of ventilation was it? The iron lung.
Negative pressure.
It's negative pressure ventilation. So you probably have seen pictures, of iron lungs. They were big cylindrical tanks. Patient, would be laying inside this big cylindrical device platform, and there would be a rubber collar around the neck so that there was a seal. And essentially, it was a vacuum type device. So the pump would create a negative pressure within this cylindrical tank, and that would allow the pleural pressure to become negative, and you would breathe just like you normally breathe, right? That's how you breathe with your diaphragm, is to create a negative intrapleural pressure, and the diaphragm descends, creates a negative intrapleural pressure. Air rushes in because of the difference, the gradient between the ambient pressure and the negative pressure in the chest, right? Same thing happened here. So this kind of ventilation worked great for patients with polio, right? Because they had a pure neuromuscular defect. So they didn't really, for the most part, didn't have any intrinsic lung disease. They just had, inability to, and no muscle function. So it worked really well. If patients developed pneumonia or they developed other intrinsic lung problems, they could put like a hood over the patient and give them oxygen through that. So that worked pretty well too. But if they got really severe lung disease, it really didn't ventilate people very effectively if they had severe intrinsic lung disease. Okay, so it was a great device, saved hundreds of thousands of lives probably worldwide anyway during the polio epidemic. A few years ago, one of the last remaining people that was in an iron lung actually in the United States died. And there's actually an article, there's an article in the LA Times about it. This woman had been in an iron lung since the 1950s. And so for almost 60 years, 50 to 60 years, she was in an iron lung. And for whatever reason, she had decided not to switch over to like positive pressure ventilation along the way, which a lot of the patients eventually did. But I think she was just used to living in this thing. And
are they in there like all day, like 24 hours a day?
Yeah.
Inside that?
Yeah. So there are little handholds here, so people can, change them, clean them and stuff like that if they need to. And they're very comfortable. I was actually able to go into an iron exhibits, and you could go in 1 minute. And I went in 1 minute, and you know, it was functioning. And so they turned it on, and it was very comfortable. You don't feel anything. There's no tubes. There's no discomfort at all. Basically, you would just, you know, would basically activate, and you take a breath in. You wouldn't even think about it. The only thing you had to do was time your speech, so that if you're talking while it was cycling, basically your words would get cut off mid-word, because you're now breathing in instead of, you know, when you talk, you have to be exhaling, right, in order to make it both words move. So if you didn't time your speech, you'd be in the middle of saying something, and all of a sudden nothing was coming out of your mouth. So that was kind of an interesting experience, but it was very comfortable. So this woman that died, you know, a few years ago, her father was taking care of her. Her mother had died. Her father had early dementia, and apparently there was it was in the Midwest, some big storm blew out the power, and the backup generator that they had failed, and so he and a neighbor hand pumped the ventilator. It was like there's a hand mechanism, and they did that for like 8 or 12 hours, and then she eventually died before they could get any help. It was kind of sad. So anyway, that was the initial thing in the 50s. Now, around the same time, in the 40s and 50s, there were other types of ventilation. What were those? Where were those? What did they use those for? It's for the operating room, right? So surgeries. So they did have some early types of ventilators for surgeries, and the eraser. Thanks. Get that on tape.
I did. I did.
All right. So the initial types of ventilators that they used in operating rooms, what kind of ventilators were those? Ventilations. Well, they had bags, but then they did develop pumps and electrical ventilators. The initial types of ventilators, they were positive pressure ventilators now, right, instead of negative pressure, so that they could overcome the resistance and compliance issues that might be involved. So positive pressure. And the mode of ventilation, what was the initial mode of ventilation, you know, that they had at that time? It was only like one mode, and that was CMV. Okay, so what is CMV? What does that stand for?
Continuous mechanical ventilation.
Or controlled mechanical ventilation, okay? Sometimes it's controlled mandatory ventilation. So there's different, you know, people use the same letters for different things, but it's basically the same type of ventilation. So this was a positive pressure ventilation where you would set a rate and you would set a pressure. And depending on the rate, so if you set it at the rate at 12 goes into 60 seconds. Every 5 seconds the ventilator would trigger, right? And it would give them a mandatory breath. And it was a pressure controlled or cycled breath, which means that you would set a pressure and it would give that amount of pressure. It wasn't a volume, it was a pressure. Okay, so you might give 25 centimeters of pressure every, you know, the rate of 12, so every 5 seconds it would trigger. Now, if the patient were to take a breath in between these mandatory breaths, what would happen? So like
Still
in
getting
here,
your full 25.
pardon? So if the patient, these are the set breaths, if the patient tried to take a breath here, what would happen? Or here?
Nothing.
You'd still get the breath, but it wouldn't be accompanied by any additional pressure.
No, they would get nothing. Okay, so there's a closed valve. So in this mode of ventilation, if the patient tried to take a breath, they would get no air. Now, that kind of ventilation works fine in the operating room when you have the patient under general anesthesia who's not breathing, right? Or may even be paralyzed. But in a patient that's awake, that's a scary thing, right? So the patient's getting breaths, they try and take a breath because they want to feel like they need a breath, and they get nothing. They're sucking against a closed valve, which basically they feel like they're suffocated. So they start fighting the ventilator. So in the operating room in the 40s and 50s, that was like not a big deal. Cases weren't usually that complicated. So by the time the patient was done with the surgery, they would extubate them, and so wasn't when they woke up, it wasn't a big problem. But as surgeries became more and more complicated, not everybody could be extubated right after the case. So they needed a way to ventilate people for a more prolonged period of time that was more acceptable to a awake patient, right? So, and actually that's why so initially, they moved these people from the operating room to the post-anesthesia care units, but then these people were staying there longer and longer and longer, and these units were not designed to do that. They're just short-term, ventilation and then extubation type units. So that's actually how intensive care units were born. That's why they were first developed. And that's also why in a lot of places in the country, anesthesia runs critical care departments, because initially critical care was done by anesthesiologists. Okay? That's really how intensive care evolved. So, so these people were now being moved to these specialized units, and people were on the ventilator for days or even weeks sometimes, and they were very uncomfortable in this mode of ventilation. So there was obviously a need to ventilate people with a different mode of ventilation, right? So what was the next type of ventilation that was developed?
AC.
Yeah, so the next type of ventilation that was developed was assist control. And initially it was also pressure cycled. So what's assist control? How is it different? Well, if you use pressure, again, you're setting a pressure, right? Not a volume. And the rate you would set the same. You would set whatever rate you want. But what's the difference between AC and CMV?
You can't do it.
So, yeah, so in AC, you can get a breath. And if it's in a pressure cycled mode, you'll get the same pressure that you have it set at if the patient takes a breath here. They'll get a full breath, whether it's a pressure breath or a volume breath, depending on what mode you're using. So now I just want to, so this was a big advance because now patients who are awake could actually take a breath and kind of help regulate their minute ventilation, which they can't do under CMV. So if their PCO2 is going, or if their pH is going down and they feel like they need to breathe faster and to compensate for that, they can now do that. Under CMV, they can't do it because they don't get any air when they breathe. Okay? So we don't use CMV anymore. It's basically not, nobody uses it. The only time patients are in CMV effectively is when you have somebody that's either so sedated they're not breathing on their own, or they're paralyzed. Then no matter what mode you have them in, effectively they're in CMV. You're controlling all of their ventilation. Okay, they have no control over it. But there's not actually a setting for CMV. Okay. So now I want to talk about about pressure controlled or pressure cycled ventilation. So these initial ventilators use pressure. So you would set a pressure, not a volume. And what's the problem with a pressure cycled or pressure mode of ventilation? So if I set a rate of 12 and a pressure, say, of 25 centimeters, they're going to get 25 centimeters of pressure. How much volume will they get with that breath?
Depends on their compliance.
Okay, good. So it depends on two main things: compliance and what's the other thing? Resistance. So anytime you think about ventilation, any kind of ventilation, you need to keep those two things in mind: lung compliance, lung/chest wall compliance, and resistance. Because those are the factors that are going to affect how well or how you're going to ventilate your patient. And they're also going to affect changes, so that if somebody decompensates suddenly in the middle of the night, that's what you need to think about. Is this a change in resistance, compliance, what's going on here? So keep that in mind. So in a pressure mode of ventilation, any change in resistance, if the resistance goes up, the airway's resistance goes up, what's going to happen? And I have it set at 25 centimeters. Say initially you have a volume of 600 with, it's producing a volume of 600 milliliters. And then all of a sudden the airway's resistance goes up. What's going to happen to the volume? It's going to drop, right? Because now you have an increased resistance. You have the same amount of pressure pushing in, so the volume has to go down. You're not going to get as much air into that patient because this increased resistance is going to prevent that. What's going to happen if the compliance goes down? Decreased lung compliance. Decreased compliance. So decrease in compliance means the lung is stiffer, right? So with the same amount of pressure, you're going to get less volume, right? So if the compliance goes down, then your volume is going to drop. Conversely, if for some reason you have an improvement in resistance, what's going to happen to your volume? It's going to go up. And if you have an improvement in your increase in compliance, it's also going to go up. Okay, so just always start trying to think in those terms when you're thinking about ventilation. What's the effect of resistance and compliance on this mode of ventilation or this particular case? So what sort of conditions increase airways resistance? That's more of a compliance problem, ARDS.
Mucus plugs.
Okay, so mucus plugs, so increased secretions in the airways, mucus plugs, what else?
Bronchospasm.
Bronchospasm. So from asthma, COPD, bronchospasm, anything that narrows the airways, bronchial wall edema. So yes, there is a little bit of increased resistance with ARDS, that's part of it, but it's not the main problem, okay? So you're right, that it does increase airways resistance, but that's the much bigger problem in those patients is a compliance issue. So if you have somebody with increased resistance, what can you do?
Fix the bronchitis.
Give
Bronchodilators.
bronchodilators. Okay, so if they have a bronchospasm, you can give bronchodilators, steroids, all the stuff that we do for those patients. You can suction them if they have secretions, which is a huge problem and probably the most frequent problem that we get into with patients on ventilators in terms of changes in all of these things. It's just transient secretions, mucus plugs, and things. So a lot of times all you need to do is suction them to improve the problem. Okay, for compliance, so ARDS, what else causes a decrease in lung compliance? Pardon?
COPD.
COPD has increased compliance. They're sort of not stiff lungs, right? They're really baggy and have decreased tissue, emphysema. They actually have increased lung compliance.
Interstitial lung disease.
Okay, so interstitial lung disease, ARDS, what else? Pneumonia. So anything that fills the air spaces, right? Anything that fills them with fluid, inflammatory, exudate, transudate, anything that fills the alveoli is going to decrease your compliance. Anything that increases the edema or stiffness of the interstitial parts of the lung will cause a decrease in compliance. So like pulmonary fibrosis does it chronically, but early inflammatory interstitial disease can also can do it acutely. Okay, so I usually tell this story, and I guess I might as well do it for the camera. So, and as an example of one of the big problems with a pressure mode of ventilation, pressure cycled or pressure controlled mode of ventilation, when I was training at LA County years ago, there was a place called the Red Blanket Room. Okay, so none of you have ever been there, right? Okay. So the Red Blanket Room was a big holding area that all the really sick patients went to because they could never get into the ICU from the emergency room. So the emergency room would send patients to this kind of holding area, and then we would take care of the patients until they either got better or until they could could get them to a regular floor, or until we could get them into an ICU. There was always a waiting list to get in the ICU. I was there virtually always. So you could rarely get anybody directly from the ER straight into the ICU. And there was a medical red blanket room and a surgical red blanket room, both. So they had the surgeons had their own red blanket room. It was called the red blanket room because, interestingly, they somewhere along the line devised the system that from the emergency room that they had to let everybody know that this patient really needed to be transported right away and not just sit around, because a lot of times people would just stack up in the emergency room in the hallways waiting for transport right to wherever they needed to go. And so what they would do is they would literally throw a red towel on the gurney so that the transporters would know that they needed to be taken right away, not to just leave them sitting in the hallways because they were really sick. So this red blanket room, the medical red blanket room, was a big open ward with beds separated by curtains. And over each bed was a little EKG monitor, but it wasn't centrally monitored. It was just over the bed, over each bed. There was literally no other monitoring in this unit. And it was a very chaotic place. There were probably about 15 patients. There were probably about 2 or maybe 3 nurses and a slew of house staff, residents, interns, medical students in this unit, and usually one respiratory therapist. So what would happen is patients would come into the emergency room with whatever problem, they would get intubated. And if they were a medical patient, they would send them to the red blanket room because there was no ICU bed. So they would go to the red blanket room, but when I first started working there, they did not allow us to use regular ventilators in the red blanket room. Okay, so the only kind of ventilators that we could use were what were called IPPB machines. Has anybody ever heard of that? You've heard this.
I've heard the
so
story.
You've heard of it. So IPPB stands for intermittent positive pressure breathing. Okay, it was a little machine. It was a box about so big. They were always green, made by the Bird Ventilator Company, and they at that time in the United States, they were mainly used to give aerosol nebulizer treatments. Okay, so bronchodilators. And the feeling was that, and it was at that time the most commonly prescribed treatment of any kind, not just respiratory, of any kind in the United States. That's how common this was. You guys have never heard of it. So I'm not saying you should have, I'm just saying it's remarkable how things change, right? So this device was actually designed mainly to give aerosol medications, but it could be used as a ventilator, as a positive pressure ventilator. You could actually set a rate, but it was pressure cycled. So you actually set a pressure and a rate, and you could set the FiO2, or you could entrain oxygen through it. So you could actually ventilate somebody with one of these. Normally, if you weren't ventilating them, there was just a mouthpiece, and the patient would just suck in, and the aerosol would entrain through it. And what it did was when the patient took a breath, it would actually trigger a positive pressure, and it would inflate the lungs, or at least that was the thought. And it was mainly used, I mean, the reason why it was so widely used is that everybody post-op was on this because they thought it would decrease atelectasis, post-op atelectasis. So virtually any patient with any significant operation, abdominal, chest operation, they all got put on this after post-op. And that's really what it was designed for. But like I said, you could use it as a ventilator, but it was a pressure mode of ventilation. So these patients would come over from the emergency room intubated for whatever their underlying cause was. And you would say to the respiratory therapist, okay, I want a rate of 12, and I don't want a pressure, I want a volume, right? So I would say, you'd say, okay, I want a volume of 600 millimeters, a rate of 12, and an FiO2 100%. So the therapist, what would they do? Well, there's no volume setting on this machine because it's a pressure ventilator, pressure cycled ventilator. So they would tweak the pressure knob to adjust, and they would get a plastic bag and they would actually measure the expiratory volume that the pressure would generate. So they would tweak the pressure until they got the volume that you were asking for. And once they got that volume, they would just leave it at that pressure, right? That's how you do it. There's no other way to do it. So they would set the patient up on these machines, and it worked fine for certain patients. So if a patient came in with a drug overdose and they have no lung problem, they just are, over-narcotized or sedated, and they're not breathing, and they get intubated in the emergency room. And those people, you kind of just wait for them to wake up, and then you extubate them, right? Those people did fine usually on this, okay, because there was nothing wrong with their lungs. But if a patient came in through the emergency room with an aspiration pneumonia or some other kind of pneumonia, what would happen? So the patient would come in, I tell the therapist, okay, I want, this volume, this rate, this FiO2, and they would do everything. They would set them up so that they say they had 25 centimeters, created this amount of volume. They'd set them up and they'd leave them. And they'd get busy and they'd go off and do other things because there were lots of patients there. So what would happen to these patients? What happens to a patient usually when after you first get them with bad pneumonia on a ventilator? What happens to their lungs? Do they get better initially? Usually they get worse in the beginning, right? You're giving them fluid, they have all this inflammatory exudate, you're pouring fluid into their alveolar spaces, maybe they were dry to begin with, now they're wet. So what happens? They get worse. So what happens to their lungs when they get worse? What happens to the lung compliance? Decreases. And what happens to the airways resistance? It also goes up because they're developing all these secretions and nobody's bothering to suction them very frequently, right? So what would happen to these patients? Well, I told you the only monitoring in this environment that we had was basically a little bit better than an oscilloscope over their bed for their EKG monitoring. And there was no central monitoring, so there were no real alarms that would go off anywhere unless the patient kind of went flatline. The little thing would go off, right? The little alarm. But we didn't have pulse oximetry, and we didn't really have any other kind of monitoring in this area. So what would happen is they'd come in, they'd be doing fine for several hours, and then in the middle of the night they would just crash suddenly, or seemingly suddenly. Probably this stuff had been going on for a while, but nobody would know, and and they would arrest. And some of them would make it, some of them wouldn't. So it was really a bad way to ventilate patients, and eventually we got it changed so that we got volume cycle types of ventilators, real ventilators into that area. But in the beginning they wouldn't let us have those. But I bring up this story.
Was that like a mask?
No, this was through an endotracheal tube.
Okay.
But the point of the story is the changes in compliance and resistance if you're using a pressure mode of ventilation, a pressure cycle ventilation, you're not going to deliver the volume or the minute ventilation that you need to adequately ventilate that patient. Okay, so that was the problem with pressure ventilation. Now that device, like I said, wasn't really designed to be doing that kind of ventilation, although it can be done. And the newer types of pressure modes of ventilation that we're using today, obviously we have much more sophisticated ventilators, so alarms go off, right, when there's a problem. But the reason for those alarms hasn't changed, okay? So those types of things, changes in compliance and resistance, are really going to affect the way you ventilate people if you're using a pressure cycle type of ventilation. So that's kind of the point of the story, okay? All right, so the next type of ventilation that came about was assist control using volume cycle ventilation, okay? And so this was considered a big advance because now, okay, so now not only could the patient regulate their own minute ventilation by taking breaths, but now you could guarantee a minute ventilation with your mandatory breaths, right? The rate is controlled. Now you're setting a volume, and you're setting, say, a rate of 12. So now my minute ventilation is going to be 7.2 liters, guaranteed. And if the patient breathes above that, they'll get more than that. But at least I'm guaranteeing a minimum ventilation for that patient, which we couldn't do with the pressure mode. initially. So what are the problems with this mode of ventilation? With this volume cycle, volume, so now we have volume cycle.
Well, as that volume, then you can have pretty high pressures.
Okay, so if you're cycling volume and you're absolutely giving 600 cc's of volume, and you have a change in your resistance, so now let's say the resistance goes down. Well, say the resistance goes up, okay? You have secretions in your airway, or you have atelectasis, or you have mucus plugs. What's going to happen to your volume? Well, it's still going to push in 600 cc's of volume, but what's going to happen? The pressure is going to go off the wall, right? Because now you're putting the same volume against a lot of resistance. The pressure that it's going to require to deliver this volume is going to go really high. What's the risk of that? Barotrauma. So how do you prevent that in this mode?
Set a max pressure that it can go.
Right, so you set a maximum pressure, a pressure limit. And how does that work? Well, there's what's called a pop-off valve, where once that limit, that pressure that you've set is exceeded, the valve pops open and it releases the excess pressure just into the air. So it protects the patient from seeing any more pressure than what you've set as a maximum. So if you set it at 40 centimeters, it'll never go above 40. It won't get the volume either for that breath, right? But an alarm will go off telling you that the pressure limit is exceeded. So you know there's a problem at that point. Okay, so the same thing with compliance. If the compliance goes way down suddenly, like you, whatever, go into pulmonary edema for whatever reason, and the compliance drops, your volume, it'll still try and put in this 600 cc volume, but the pressure will go way up. Okay? All right, so that's one problem with this type of ventilation, but again, we have alarms that will prevent you from having, will protect you against the barotrauma. So another problem that can happen with this mode of ventilation in assist control is if the patient starts breathing really fast, for every breath they're going to get a full tidal volume, right? If they take a spontaneous breath. So if they're breathing faster than what you've said, if they're breathing 30 instead of 12, every one of those extra breaths, they're going to get a full tidal volume. So what potentially is going to happen from that? What's going to be the effect of that?
Their CO2 is going to drop.
Okay, so their CO2 will drop. They become very alkalemic suddenly, which is not a good thing. So what can you do in that situation?
You can switch them over to SNP.
Okay, so you can switch them to another mode. What else can you do?
Paralyze them.
You can paralyze them. What else? Short of paralysis. But you can reduce the volume and
Decrease
you
the
can,
set rate.
well, what does decreasing the set rate do?
Oh, actually, that won't do anything. 'Cause
Okay,
they'll still be able
so
to take
it's a
spontaneous
common
breaths.
medical student mistake or intern mistake is in the beginning of the year is to decrease the rate to try and decrease the ventilation, right? If you're in this mode of ventilation, it doesn't matter. If they're breathing 30, they're going to get 30 full breaths a minute, even if you haven't set it 2, right? So decreasing the rate will not help. Decreasing the volume might help because that will decrease the amount of volume with each breath. They may compensate for that by breathing even faster, or they may not. But that's one thing you could try. The other thing is just to sedate them more, right? So that they're not breathing so fast. You don't necessarily have to go all the way to paralysis, but you can sedate them so that they don't have that high rate. And like you said, the other thing is to switch them to a totally different mode of ventilation. Okay? Anybody have any questions about assist control? Okay, so assist control is still one of the most widely used modes of ventilation. So even though this was developed in the early 60s, probably. So we moved from the 50s to the 60s now, right? All right, so now around the mid 60s, around 1965 and that around next mode of ventilation was developed. What was that? Close, yeah, it was not SIMV, it was IMV, okay? So, what does that stand for? Yeah, or mandatory ventilation. Intermittent mandatory ventilation or intermittent mechanical ventilation. So what does that mean? So if I set a rate of 12 and a volume of 600, what's going to happen in this mode of ventilation? So they'll get, every 5 seconds, they'll get a 600 cc tidal volume, right? And if they try and take a breath in between those breaths, the set breaths, what is going to happen? What are they going to get?
Whatever they can pull.
Yeah, whatever they can pull on their own. So that could be, if this were a volume curve instead of a pressure curve, that could be, you know, a little volume if they can only take a little breath. It could be a big breath. It could be bigger than your set breath. It could take a liter or more. They can take whatever they can generate on their own. They are going to get. So it could be anywhere, anything. Okay? But they're not going to get your set volume like they do in assist control and take their spontaneous breaths. Okay, so this mode of ventilation was designed as a mode of weaning. Okay, it wasn't designed as a mode of, like a primary mode of ventilation, just to ventilate people with. It was really designed as specifically to wean patients. So how did that work? Why was there a need for it, felt to be a need for that, and what was the theory or the philosophy behind it? Does anybody know? How did we wean people from assist control? If you have somebody on assist control, how do you wean that patient?
On a T-piece?
Yeah, okay, so back then, we would use what was called the T-piece, which was a T-shaped plastic tube. It's like a piece of plumbing, right? It's about this big, you know? And you would attach you would disconnect the patient from the ventilator. You would attach the end of the endotracheal tube to this tube, to this T-piece, and you just put oxygen, you run oxygen through here, and the patient would just breathe in and out through the endotracheal tube. They would breathe in oxygen, and you know, they would exhale out. So they're basically off the ventilator, but still intubated, right? That was the spontaneous breathing trial. It was called a T-piece trial. And what you know, initially, since they didn't have pulse oximetry back then, all you would do is you would watch their vital signs, and you would set parameters for their vital signs. And if they developed respiratory distress with increased respiratory rate or decreased respiratory rate, if they were too sedated, or if they either heart rate went way up or their blood pressure went way up or way down, then you would put them back on the ventilator. So the way you wean somebody is you put them on a T-piece. You would allow them to go for as long as they could before they developed some, just, you know, until they developed some sign of distress, and then you'd put them back on the ventilator. That could take 5 minutes, it could take 2 minutes, it could take 30 minutes. And then you would gradually increase the amount of time that, or try and increase the amount of time that they would spend on the T-piece off of the ventilator. And once they got up to about 2 hours on the T-piece, they were felt to be able to be breathing okay on their own. You would extubate. Okay, so that's how weaning was done on assist control, or from assist control. Well, if you think about it, the rationale was you would, by doing these progressively longer T-piece trials, it would allow the patient to gradually build up the muscle strength to be liberated from the ventilator. That was the idea. But the problem was people were saying, yeah, but we're fully supporting them on assist control. They're doing almost no work of breathing on assist control, right? Because they're just initiating the breath, even if they're breathing on their own. -1 or -2 centimeters of pressure will give them a full volume. They're not doing hardly any work. So, they're going from doing no work or almost no work on the ventilator to doing 100% of the work off the ventilator. So people thought, well, maybe that's not the best way to wean somebody from mechanical ventilation. Maybe we should have a more gradual process where we support them partially and gradually remove that support. You know, initially support it completely and then gradually, you know, work it so that they gradually improve. So that's why IMV was invented. And the idea was you would start them out on a rate of, you know, 12 or 15 or whatever it was. And as you, when you thought the patient was ready to start weaning from the ventilator, you would go down on the step rate. And you'd go from 12 to 10 to 8 to 6 to 4 to maybe 2. And then you could either extubate them or do a T-piece at that point. And this process could take anywhere from days to weeks, depending on the patient. And as you went down from one level of support to the next, the idea was the patient had to pick up the difference on their own spontaneous breaths. And if they were tolerating that well, you would go down to the next level, okay? So it was thought to be a better way to wean people. And that's really why it was developed. Soon it became the most widely used mode of ventilation in the United States, not in Europe, not in the rest of the world. But in the United States, it became the most widely used mode of ventilation, even though it wasn't really designed to just start people out on that. And still, there's this bias or this feeling amongst, you know, older respiratory therapists and nurses, you know, when you say, well, I think the patient is ready to start weaning, and they're on assist control, they always want to move an IMV. Well, can we move an IMV now? Because that was kind of the way it used to be done years ago. If you started out on assist control, you'd go to IMV and then wean them that way. Or you would just start them on IMV to begin with. Not even bother with the assist control. You would fully support them in the beginning with enough breaths so they weren't doing much work, and then you would wean them. Okay. So one of the problems with IMV, when after it was introduced, was that if the patient took a breath here instead of down here, what would happen? It's called breath stacking. So they would get, potentially could get a higher volume than what you set. So you may have it set at 600, and if they breathe, take a breath on top of the 600, they could get a liter or 1,200 cc's, and there was a risk for barotrauma, and there was a risk for, and there was, you know, what was considered ventilator patient asynchrony. So the patient wasn't really synchronizing well with the ventilator. Wasn't a big problem, and most people that are put in an IMV mode back then, within a day or so, they just gradually adjusted to the ventilator and they synchronized pretty well. But the ventilator companies thought that this was like a good way to make money. So they developed synchronized IMV, which is what we have now. It's called SIMV. And what it did was the ventilator would sense when the patient took a breath, and then it would, the next mandatory breath, it would trigger at that point so that they weren't stacked. So it would sense the patient's breaths, and then it would trigger the mandatory breath after that so that there was synchronization. So this wasn't really a big problem, but the ventilator companies made it out to be a really big problem, and they sold an entire generation of ventilators based on the S. There was no difference in the ventilators other than that between the prior generation of ventilators and this generation. Okay, so that was, the SIMV came out probably in the early 70s. Questions about IMV or SIMV?
Is IMV used?
All the
It's always
ventilators have
SIMV.
SIMV now. There's no such thing as just IMV. All right, so what was the next type of major type of ventilation that was developed after that? Now you're moving into the mid-80s, so about 1985 now. What, BiPAP? No, that's probably a little later, but close.
CPAP.
Well, okay, so CPAP, is CPAP a mode of ventilation? No. So CPAP is just continuous positive airway pressure. CPAP was available years before that, as was PEEP. Okay, so PEEP was developed in the 60s. In fact, in the first description of ARDS by Petty and Ashbaugh in 1967, they described the use of PEEP to treat it, which was interesting because they were describing the syndrome and they already had figured out a way to actually treat it. So PEEP and CPAP have been around, but neither of them are modes of ventilation. They're something that you could use with ventilation to support ventilation, but they're not ventilating people, right? You're not giving them volume, you're not giving them, you're not assisting their breathing in either of those modes. So do you understand the difference between, as long as we're talking about it, between CPAP and PEEP? So what's the difference? Is there a difference? CPAP stands for what? Positive airway pressure. Continuous positive airway pressure. And what does PEEP stand for? Positive end expiratory pressure. So essentially CPAP and PEEP are the same. Okay? The only difference is if you have somebody who's spontaneously breathing without mechanical breaths, that patient is on CPAP. Put a them on it. If they're getting mechanical breaths, then the only time they have, it's at end expiration that they maintain that pressure. During the breath, they're not at the CPAP level or the PEEP level, right? They're much higher pressure than that. But at the end, they're at that PEEP level. So it's really the same. And in fact, on the ventilators, on a lot of ventilators, the setting for PEEP and CPAP is the same button because it's really the same thing. And it's really just a matter of whether the patient's breathing spontaneously or whether they're getting mechanical breaths. It's really the main difference between the two terms. So you should think of them as almost equivalent in terms of the effect that they have on alveoli and on alveolar recruitment. Okay? So, so PEEP and CPAP are not modes of ventilation, but they were developed in the 60s. SIMD in 1985, and this was around 1995 now. The next mode was pressure support. Okay. Now there were other modes being developed along the line. I'm not saying these are the only things, but in terms of major types of ventilation that we're still using today, this was the next major thing, pressure support. So what is pressure support, and why was it developed? Pressure support was developed as a mode of weaning again, just like IMV. It wasn't developed as a mode to ventilate people with as a primary means of ventilation. It was specifically developed as a better way to wean, what was thought to be a better way to wean patients from the ventilator. So what is pressure support? Pressure support is a flow cycled pressure limited ventilation. What does that mean?
It offers an amount of pressure at a certain time. But is this, maybe I don't understand, right? Pressure support, is that the same as tube comp in the sense that it's...
Well,
given a
tube
certain
comp
amount
is
of pressure?
probably a type of pressure support.
Okay.
It's a variable pressure support, essentially. So pressure, when we say it's pressure limited, that means we dial in the pressure. It's a pressure mode of ventilation. It's not a volume mode. You're not giving them a volume, right? You're ordering a pressure, okay? So say you order 20 centimeters of pressure. It's going to give them 20 centimeters of pressure when they take a spontaneous breath and trigger it, okay? So it's triggered by the patient, first of all. So it's triggered by the patient's breath. It's not, you don't set a rate with pressure support. You have to have a spontaneously breathing patient. If you have a patient who's not spontaneously breathing, I mean, you put them on pressure support, they will be apneic. If you have them on a neuromuscular blocker and you put them on pressure support, they will be apneic. They will get no ventilation. So they have to be spontaneously breathing. So if they initiate a breath, They are spontaneously breathing, they have a spontaneous rate, and they initiate the breath enough to trigger the ventilator. And you can set the amount that it needs, they need to generate to trigger it. It will give them whatever pressure you've dialed in. Okay, very similar to that old kind of pressure, you know, the first one we talked about, the little bird ventilators. But there's some significant differences. So on that type of ventilation, you would dial in a pressure, and the ventilator would trigger up to that pressure, and then it would drop off, and that would be the end of it. You know, it would release. And that has to release, or else you can't breathe out, right? So in this mode of ventilation and pressure support, it's pressure limited because we dial in a pressure, but it's flow cycle. Well, what does that mean, flow cycle? That means the ventilator senses the flow rate that it's delivering. When the flow rate drops down to about 25% or so of the initial flow rate, it releases. Okay, so that's how the ventilator knows, you know, in quotes, knows to stop giving that pressure. As you approach, you know, initially when you take a breath, if you look at flow rates, your initial flow rate is very fast. The flow is going into your lungs very fast. As you approach your tidal volume, you know, the volume that you're going to breathe to, the flow rate drops off, right? As you go up to, say, your tidal volume is going to be 600 cc's. If you're just breathing spontaneously, you take a breath in, your initial flow rate going into your lungs is very fast. As you get close to filling your lungs with that volume, the flow rate drops off. Eventually it goes to zero, right? At the maximal point of your inspiration, the flow now goes to zero. There's no flow. It stops. And then when you exhale, it's passive, right? You just breathe out. It doesn't take any work normally. So in this mode of ventilation, it's the same thing. As it gets close to zero in the flow rate, or 25% of the initial very fast flow, the ventilator releases and it allows the patient to exhale. So that's why it's called flow cycle, because it's actually sensing the flow from the ventilator, from the patient. And if the patient is taking a really big breath in, you know, they're going to get more air, and if they are not, they're going to get less air. In terms of the assistance that it gives for breathing, it's kind of like if I was trying to lift, or you were trying to lift a very heavy suitcase. Okay, you're pulling up on the handle, and it's a lot of work, right? It's really heavy. And I come up behind you, and I grab onto the handle with you, and we pull together. That's pretty much how pressure support works, okay? It's assisting that work of breathing that the patient is doing. And if you dial in, and if I pull hard enough, you don't have to lift at all, right? All you have to do is start to lift so that I know when to pull, right? And that's the patient's initiating the breath. And then I can do all the work, you know, if you're lazy. Or for that breath, you know? So from breath to breath, it's going to change. Maybe, you know, the patient takes a really big breath sometimes. Another time they take a very weak breath. Well, I'm going to give them the same amount of support with each of those breaths. So sometimes it's going to help them a lot. Sometimes it's not going to do anything for them. Makes sense? Okay. So why was this developed as a mode of weaning? Because pressure support, the idea behind it was, as opposed to assist control with the T-piece trials where the patients were doing all the work or none of the work, depending on whether they're on the T-piece or not, right? In IMV, as you go down on the rate that you set, the patient's doing all the work in between those set breaths, or they're doing none of the work during the set breaths, right? So if I set it at 12 times a minute, they're doing no work. Whatever they're breathing on top of that, they're doing all the work. So it's all or none. But it's breath to breath, whereas with assisted control and T-piece, you're just putting them for an extended period. They're doing all the work or none of the work. Well, with pressure support, the idea was we'll start them out on a lot of pressure to almost fully support them. or even fully support their breathing, so they're doing almost no work. And then we'll gradually go down on the pressure. And as we go down on the pressure, the patient has to lift more, right? They have to work harder. Or as they are able to work harder, we can go down on the pressure. So from breath, but it's every breath. Every breath gets some support as their condition improves and their work decreases, and they're able to do more and more work of breathing. When you get down to about 5 centimeters of pressure, the idea was that would be the amount of pressure that would be required to overcome the resistance in the endotracheal tube. And you could probably extubate them from 5 centimeters of pressure support. Now we have tube compensation, which is really a type of pressure support. Which allows, basically, based on the size of the endotracheal tube and the patient's inspiratory flow, it actually adjusts the pressure support. So it's probably somewhere between 3 and 5 or 6 centimeters of pressure support equivalent. So when we have them on that mode of ventilation, or on tube compensation, they're basically doing all the work of breathing, is the idea. Okay? So it was designed as a mode of pressure of weaning. We can use it in addition to, with other modes of ventilation though, to support spontaneous breaths. So sometimes with SIMV, for the non-set breaths, for the patient's spontaneous breaths, we'll put them on pressure support, maybe give them 10 centimeters or 5 centimeters of pressure support. So those spontaneous breaths that we're not, that the patient's doing on their own, get a little bit of support, or get just enough support to overcome the resistance in the endotracheal tube, so they're not doing extra work for those breaths. And that's the idea behind it. Can you use pressure support with assist control?
Well, they're already receiving set volume or pressure on assist control.
Right.
On their spontaneous breaths.
Right, so the answer is no. You can't use pressure support with assist control because every breath is getting a full tidal volume. Okay, so you can use it in IMV. You can use it by itself. There are other modes of ventilation which we may or may not have time to talk about, which you can use it with, but only in cases where the patient can take a spontaneous breath, and those spontaneous breaths are not fully, full mechanical breaths like an assist control. Okay. So I think we're up into the 1990s now. Okay, so we're almost into this century. It's exciting, right? We're almost done with the talk. Okay, so do you have any questions about pressure support, how it works? All right, also in probably the late 80s, early 90s, there were other modes of ventilation starting to be developed and tested and used, okay? One of them is pressure control, okay? So pressure control is a pressure limited form of breathing, just like pressure support, but what's the difference? Anybody have any idea? How is pressure control different than pressure support? You've heard of pressure control, probably, no? Maybe? Okay. All right. Pressure control is time limited, or time cycled, sorry. It's pressure limited. So what does that mean? Well, that means you set a pressure, just like with pressure support. But what cycles the ventilator? Instead of the patient's flow rates cycling the ventilator, the inspiratory flow rate, remember I said it cuts off after it gets down to 25% of the initial flow rate with pressure support. With pressure control, it's really a time cycle mode of ventilation. So you set the time that you want inspiration to be. Or you can set the IE ratio, and the IE ratio will be dependent on, it'll basically calculate the time for you based on the rate that you've set. So if you set a rate of 12, every 5 seconds that patient is going to have a breath, right? Have a breath every 5 seconds. Okay, so in pressure control ventilation, you can set what you want the inspiratory time to be. So say I want an IE ratio. What's the normal IE ratio that we normally breathe with? 1 to what? 2. Okay. So expiration is about twice as long as inspiration normally with normal breathing. Okay. Remember, expiration is passive. So you breathe in, and then it takes longer to get the air out. Okay, because it's passive. You're not forcing it out, right? So that's the normal IE ratio. So if you're breathing if this period is every 5 seconds, you know, the inspiratory time will be, you know, a lot shorter than the expiratory time. So say I set this at 1.5 second inspiratory time, that's going to allow him breathing every 5 seconds, then you're going to have around a 3.5 second expiratory time. It's not quite 2 to 1, or 1 to 2, right? You have to adjust it a little, 1.7 to whatever, 3.3, something like that. Okay, that would be a normal IE ratio. Well, you can, by adjusting the inspiratory time, what if we make the inspiratory time longer? Then what's going to happen to your IE ratio? It's going to allow less time for exhalation, right? So your IE ratio is going to go to maybe 1 to 1. So maybe I'm going to now have 2.5 second inspiratory time and a 2.5 second expiratory time. Or say I want to have what's called inverse ratio respiration, where I want to have a 2 to 1 ratio. Then I can do that with pressure control because I can set the inspiratory time at whatever I want. So you can tell it, you know, I want a 2 second inspiratory time, or you can say, I want a 2 to 1 ratio, and it will automatically calculate the time based on the rate that you've set. So the problem with this kind of ventilation is it's not very comfortable, right? Because you're not used to having a 2 to 1 IE ratio. That means it would be like holding your breath for a second or two and then letting it out. That's a very abnormal way to breathe, and it's very uncomfortable for patients. So most of the time in pressure control ventilation, you need to really sedate them heavily or even paralyze them if you're going to be using these different IE ratios. And why would you ever want to use that?
To allow more time for oxygen exchange.
Okay, so the thought behind, there's 2 things, okay? First of all, by using a longer inspiratory time and allowing less time for exhalation, what happens? You get air trapping, right? Which basically means you get like an auto peep or an intrinsic peep effect from that, okay? So initially, that wasn't really well understood. In fact, there was a whole mode of ventilation that was called inverse ratio ventilation back in the 80s that was developed, and people were using it a lot initially until they really understood the whole thing it was doing was creating auto peep or intrinsic peep in patients with really severe ARDS. That's basically where it was used and still used. So one benefit is that you get this air trapping auto peep or intrinsic peep effect, but there's really not a big advantage of that kind of peep from just applying peep with the ventilator. The other advantage, though, is that the flow characteristics in this mode of ventilation are different than in volume cycle ventilation. The delivery, the way the gas is delivered is different. Now, if you think about pressure and volume relationships, the compliance and resistance doesn't change. And I set a set pressure, I'm always going to get the same amount, I should always get the same amount of volume, right? If the resistance of the lung and the compliance is constant, and I set a certain pressure, every time I give that pressure, you should get a set volume, right? Conversely, if I give that same volume that's delivered, say you set it at 25 centimeters, what is this? Say you're supplying a pressure of 25 centimeters, and that's generating a 600 cc tidal volume, right? And nothing changes Everything's static, compliance is the same, resistance is the same. You know, we're doing this from 1 minute to the next minute. Nothing is changing, okay? Every time you give 25 centimeters, in theory, you should get about 600 cc tidal volume, correct? Okay, conversely, if I give a 600 milliliter tidal volume, how much pressure should it take to generate that? 25 centimeters, right? They should be the same, they should be equivalent. But in fact, they're not always equivalent. And that's one of the issues. So when you have somebody who's in volume cycle ventilation, who has very high, like their pressures are very high, you know, their peak pressures and their plateau pressures are really high, you're not able to ventilate them adequately, like your patient that you have in 15. One thing that you could consider doing is switching to pressure control. Now, intuitively, based on what I just said, it shouldn't make a difference, right? If I go from a 600 cc volume cycle ventilation and it's generating, say it's generating 35 centimeters. It's taking 35 centimeters to get this volume. If I switch into pressure control and I give them 35 centimeters, it should just give me 600 cc's, right? I mean, the physics of it. But in fact, it doesn't work that way. And it may only take 30 centimeters of pressure to give that amount of volume. And the reason is the difference in the way the flow and the gas is delivered between the two different modes. Okay, so in pressure control ventilation, you can oftentimes ventilate people with lower pressures and generate the same volume, which is counterintuitive, right? It just doesn't go along with the physics of what you're taught, of, you know, the physics that we've been taught. Because the PV should be constant, that product should be constant, the pressure volume product. But it's the flow characteristics that makes it different. So you can get by with a lower pressure a lot of times. So that's one advantage of using pressure control. A lot of the newer modes of ventilation, bi-level, airway pressure release ventilation, are pressure modes of ventilation. You're not really dialing in a volume, you're dialing in a pressure. I don't really have time to talk about those modes. Those are newer modes. They are useful. Probably you should have a pulmonologist or an intensivist helping you manage those patients. So I'm not going to go into those right now. We can have another talk on that if you want. But the modes that I've talked to you about, so assist control, SIMV, pressure support, probably not even pressure control. Those three modes, assist control, SIMV, pressure support, you should be able to ventilate 95% of patients, maybe more, with those modes, and not knowing anything else. As a general internist, that's all you should need to know about. If you get to the point where you can't adequately ventilate somebody with one of those modes, you need to get somebody who knows a lot about ventilation, a specialist. Okay. And you can see from the people that we ventilate in here, I mean, I don't know that I don't think this month we've used any of those other modes of ventilation on any patient, and we've got some pretty sick patients with ARDS. So you don't necessarily need to know those other modes. Definitely not as an internist. If you're interested in reading about them in the database, in the articles database online, you can go in there and there's articles on, there is an article on all those newer modes of ventilation. I'll go through a discussion of each of the different types. Okay, any questions about anything? All right, well, that's part one. So part two will be on weaning. Okay?